The goal of this video lecture is to review the diagnostic criteria for the different disorders that are classified as feeding and eating disorders in the DSM, and to discuss the characteristics that distinguish these disorders from one another. So the category of feeding and eating disorders in the DSM includes disorders that are characterized by persistent disturbances in eating and related behaviors that result in altered consumption of food or altered absorption of food that impair health or functioning. There are a range of disorders in this category in the DSM. One of these disorders, pica, can be diagnosed on its own or in combination with the other disorders. The other eating disorders are mutually exclusive, so if an individual is given a diagnosis of one of the remaining 5 disorders, they can only have one diagnosis. So you can't give more than one diagnosis of rumination disorder, avoidant restrictive food intake disorder, anorexia nervosa, bulimia nervosa, or binge eating disorder, because they share many characteristics. So the goal is for the clinician to decide which diagnosis best captures the nature of the individual's disordered eating behavior. So when we think about this broad category, often we think of the first 3 of these disorders as being more feeding-related disorders, and when people talk about typical eating disorders, they're often referring to the set of the last 3 disorders. So our first feeding disorder is pica, and pica is characterized by persistent eating of non-nutritive, non-food substances over a period of at least 1 month. So this eating is not developmentally appropriate or culturally supported, and it's not better explained by another disorder. So this can include things like eating paper, eating clay, or eating chalk. It is more common in childhood populations. We sometimes also see pica developing during pregnancy. So individuals with pica often are compulsively eating non-nutritive, non-food substances. And this eating is causing distress or impairment. So the person may experience digestive problems as a result of the fact that they are eating foods that cannot be digested, or they may be experiencing other problems. So pica can be diagnosed on its own. You can also receive a diagnosis of pica in combination with other eating disorders. And remember that that is not true for our other disorders in this category. Our next feeding disorder is rumination disorder, and the defining characteristic of rumination disorder is repeated regurgitation of food over a period of at least a month. So the person consumes food and they swallow it and they regurgitate it into their mouth. It may then be rechewed and swallowed, or it might be spit out. And this is not due to any medical condition, so it can't be explained by any kind of physiological problem. And also remember that this is a disorder that cannot be diagnosed in combination with other disorders. So if this is occurring in the context of another eating disorder like anorexia nervosa or bulimia nervosa, we would give that diagnosis. But if we're not meeting criteria for those other diagnoses and an individual is repeatedly eating food and then regurgitating it and either swallowing it again or spitting it out, a diagnosis of rumination disorder would be most appropriate. Typically, this is occurring daily and often multiple times per day in order to qualify for a diagnosis of rumination disorder. Our next disorder is avoidant restrictive food intake disorder. So this is a diagnosis that is characterized by a feeding disturbance that leads to a failure to meet nutritional or energy needs that results either in weight loss or nutritional deficiencies, or that impairs social functioning. So this might be avoiding eating food entirely. It might be avoiding foods with particular kinds of sensory characteristics, or it might be avoidance of certain subsets of foods. And this can vary individual to individual. So many individuals with avoidant restrictive food intake disorder will restrict their food intake to a narrow set of acceptable foods. So for example, they might be many bland white foods, often simple carbohydrates. So for example, white bread or white rice or chicken. They may not ingest fruits or vegetables. So they are restricting their food intake not necessarily because of concerns about weight or shape. That would be more consistent with the other eating disorders. Often it's related to either an aversion to particular foods or a range of foods, or to aversion to particular kinds of food textures, so people who don't like crunchy foods or slimy foods, or other concerns about consequences of eating food. So for example, people report avoiding sets of foods because of concerns about gastrointestinal consequences of eating those foods. So when an individual is restricting their food intake to an extent either that they're not able to maintain their weight, or if they are getting sufficient calories but they're not meeting their major nutritional needs, or if they are having trouble with psychosocial functioning. So for example, if their social interactions are limited because the foods that they find acceptable are so limited, all of those would be evidence that their feeding disturbance is consistent with a diagnosis of avoidant or restrictive food intake disorder. Our remaining set of disorders are more what we think of when we talk about typical eating disorders. So the first eating disorder that we'll talk about is anorexia nervosa. So the criteria for anorexia nervosa in the DSM-5 are the restriction of energy intake relative to energy needs or requirements that leads to a significantly low body weight. So in DSM-4, there was actually a threshold for how low an individual's body weight had to be in order to meet criteria for anorexia, but this has been eliminated in the DSM-5. So there's no longer a strict weight cutoff, but an individual needs to be restricting their energy intake to the point either that they are not maintaining a normal body weight or that they are not making appropriate developmental gains when we're looking at children or adolescents. In addition to this food restriction, anorexia is characterized by an intense fear of gaining weight or becoming fat, or this might also be manifested as persistent behavior that interferes with weight gain even though a person is already at a significantly low weight. So most individuals with anorexia nervosa will report that they have a concern about gaining weight or becoming fat that they are consciously aware of, and that this drives their caloric restriction. But some individuals with anorexia, even though they're significantly underweight, will report that they're not worried about gaining weight or becoming fat. So if an individual says that they're not worried about their weight, they're not worried about their shape, but they still refuse to take in sufficient calories and are significantly underweight, they would still also qualify for a diagnosis. And then finally, the disorder is characterized by disturbances in the way that an individual perceives their weight or shape. So an individual might have distorted perceptions of their size and perceive themselves to be larger than they are. An undue influence of body weight or shape on self-evaluation, so the way the person feels about themselves or their mood on a given day is very closely tied to their weight on that day or their eating behaviors. Or another defining characteristic is that a person lacks recognition of the seriousness of their low body weight, even though they might really be at risk for severe medical consequences. So anorexia is really characterized by a failure to maintain adequate caloric intake to maintain a minimum body weight, and these additional associated characteristics. There are some relevant specifiers in the DSM for further characterizing episodes of anorexia. So there are two subtypes of anorexia nervosa. The first subtype, the restricting subtype, is defined by a failure to maintain weight or weight loss primarily through restriction of food intake. So an individual with the restricting type does not engage in binging or purging behaviors. In contrast, an individual with the binge eating purging subtype of anorexia may engage in binging and purging behaviors, and after engaging in binging behaviors, they prevent weight gain through restriction of their food intake, and they may also engage in compensatory behaviors and purging behaviors, such as vomiting, misuse of laxatives, or excessive exercise. So the episodes of binge eating that are seen in the binge purge subtype of anorexia are typically smaller than we see in bulimia nervosa. So episodes of binge eating may not meet DSM criteria for an episode of binge eating, but may be perceived of by the individual with the eating disorder as a binge eating episode. So an episode of binge eating that would meet DSM criteria might involve eating 2 pizzas within a span of 30 minutes and feeling out of control and eating that pizza alone, versus an individual with the binge eating purging subtype of anorexia might eat 1 or 2 pieces of pizza at dinner time with their friends and feel that that constituted an episode of binge eating, and they might then engage in compensatory or purging behaviors in order to prevent weight gain from that eating behavior. We can also characterize anorexia nervosa according to the severity of the disorder, and the severity of the disorder is classified on the basis of an individual's BMI, or body mass index. So BMI is a ratio of an individual's weight in relation to their height, and the severity of anorexia is classified on the basis of DSM BMI categories. So mild severity would be an individual whose BMI is greater than or equal to 17. Moderate is a BMI between 16 and 17. Severe would be a BMI between 15 and 16, and extreme would be a BMI lower than or equal to 15. So for example, for a woman who is 5 feet 2 inches tall, a BMI of 17 would be associated with a weight of 95 pounds, so that would be considered mild. 16, so a weight between 90 and 95 would be considered moderate severity. 15 would be a weight of 85, so 85 to 90 pounds would be considered severe, and then 80 pounds or less is a BMI of 14, so anything under 85 pounds would be considered an extreme specifier for anorexia nervosa. Our next eating disorder is bulimia nervosa. So the DSM-5 criteria for bulimia nervosa include recurrent episodes of binge eating, and we've discussed the defining characteristics of binge eating in the DSM. So it's a discrete period of time, it's an objectively large amount of food, it's not appropriate for the cultural context, and it's accompanied by a subjective sense of loss of control. And these recurrent episodes of binge eating are accompanied by inappropriate compensatory behaviors in order to prevent weight gain. So remember, those compensatory behaviors might be purging behaviors, such as self-induced vomiting, or they might be non-purging compensatory behaviors, such as excessive exercise. The binge eating and compensatory behaviors need to occur at least weekly for a period of 3 months or more. So we've got a frequency criterion that it has to happen at least once a week, and a duration criterion that it needs to occur for a minimum of a 3-month period. And then, similar to anorexia, self-evaluation is unduly influenced by body shape and weight. So there are a few characteristics that can distinguish bulimia nervosa from anorexia nervosa. So we already discussed that in the binge-purge subtype of anorexia nervosa, if an individual engages in episodes of binge eating, those episodes tend to be objectively smaller and may not meet DSM criteria for an episode of binge eating. In addition, individuals with bulimia nervosa tend to be of higher weight than individuals with anorexia. So individuals with anorexia nervosa tend to be in the underweight range. In comparison, individuals with bulimia tend to be either of normal weight or may actually be overweight, and self-perception of body weight and shape tends to be more accurate in bulimia nervosa compared to anorexia nervosa. So although they may have distorted perceptions of their weight and shape, their perceptions tend to be more accurate than those that characterize anorexia. And then our final eating disorder is a new disorder included in DSM-5. This is binge eating disorder. So binge eating disorder is characterized by recurrent episodes of binge eating, and these episodes need to meet the same criteria as episodes of binge eating for bulimia nervosa. So a discrete period of time, an objectively large amount of food, not normal for the context in which it's being eaten, and a subjective loss of control. And in addition, these episodes are accompanied by at least 3 of the following symptoms. So the individual may eat more rapidly than usual during the episode of binge eating. The individual may eat until they feel uncomfortably full, so they feel very full, but they continue to engage in the binge eating. Eating a large amount of food when the person is not physically hungry. Eating alone or feeling embarrassed because of how much the person is eating. or negative affective responses to the episodes of binge eating. So the individual might feel disgusted or depressed or guilty as a result of their binge eating. The individual experiences marked distress about their binge eating, and we have a similar frequency and duration criterion. So the binge eating is occurring at least weekly for 3 months or longer. So the primary characteristic that distinguishes binge eating disorder from bulimia nervosa is the absence of those compensatory behaviors. So binge eating disorder is characterized by recurrent episodes of binge eating in the absence of compensatory responses. When we think about distinguishing among these 3 primary eating disorders, we can think of differences in weight that are typical across the disorders, and we can also think about the different behaviors that we see across them. So typically we're going to see the lowest weights in the restricting subtype of anorexia. Individuals with the binge purge subtype of anorexia are also going to be significantly underweight, but they may be at a higher weight than an individual with only the restricting subtype of anorexia. Individuals with bulimia are more likely to be in the normal weight range or may also be in the overweight range, and many individuals with binge eating disorder are either in the overweight weight range or in the obese weight range. We can also distinguish them by the presence and absence of different types of behaviors. So the restricting subtype of anorexia is characterized by restricted food intake. We also see food restriction in the binge purge subtype of anorexia, but we are also going to see episodes of binge eating. The episodes of binge eating in the binge purge subtype of anorexia are going to be objectively smaller than we see in bulimia and binge eating disorder. Bulimia and binge eating disorder, we're also going to see episodes of binge eating, but they're going to be objectively larger and meet those DSM criteria for an episode of binge eating. And both anorexia, the binge purge subtype, and bulimia are also characterized by compensatory behaviors, so purging behaviors or non-purging compensatory behaviors such as excessive exercise, and those compensatory behaviors are absent in binge eating disorder. So we can think of these disorders as existing on a continuum, both with regard to the typical weight of individuals with these disorders, and we can also think about how they relate to one another in terms of the presence or the absence of food restriction, episodes of binge eating, and the presence or absence of compensatory behaviors.